We're going to spend the next few minutes talking about patient assessment and triage with a particular focus on doing so in a remote or wilderness environment. The first thing to always consider when approaching a victim or a medical emergency is to assess the scene safety. Is it safe for you and your team to actually begin to provide care to the patient? The logic behind that is simple, is that if the scene is not safe and there's a further risk of potential injury, you don't want to make more victims. In general, there are two facets of scene safety to consider. The first and most common is going to be the environmental situation. So that might be rock fall if you're around a rock climbing area, or animals if the victim was just envenomated by a snake or attacked by a bear. Things like that you need to take into consideration before approaching the victim. The other facet is actually human, and that might be a patient who is undergoing a psychiatric emergency and might be agitated and combative, or they might be threatening assault to either you or they were an assailant on the victim. In any situation, you need to make sure that it is safe for you to proceed without injuring yourself or your team members. And if you determine that the scene is not safe, is there a way that you can make it safe? A good way to think about this is the same way that first responders, such as police, firefighters, EMTs, might take into consideration a certain situation. When firefighters arrive on scene to a burning building, they don't simply run in, they actually take a moment to assess the situation because they want to not only save lives that might be inside the building, but they want to preserve the lives of themselves and their team members. If a scene is not safe, think about ways that you can make it safe. For example, if you were trying to treat a victim of a rock fall in a rock climbing area, you might consider quickly moving them away from the wall where rocks might be falling from. Now, this does put you and your team in a small amount of risk, but if you're quick in moving the patient or extricating the patient from the scene, you might be able to prevent any injury to your team and further injury to the patient. But in every situation, it's going to be a judgment call that you might make in conversation with your team members. Once you've assessed that the scene is safe and you decide to approach the patient, the first thing you're going to do is actually obtain consent. Just as in the hospital environment, we need to actually have the patient's consent to render any medical care. Now, outdoors, Good Samaritan laws generally apply, but obviously you need to be practicing within the scope of your knowledge and in proper severity of the situation. An easy way to do this is to introduce yourself, ask the patient for their name, and then ask them if it's okay for you to help. Along the same lines, it's often good or advisable to actually let them know that you are a medical professional. If the patient says no, unless you determine that they are impaired or potentially putting others at risk, you should not engage. That will be technically considered assault. An example of a situation might be somebody who has sustained a head injury and is declining any medical care. You might actually hang out on the periphery of the environment where the patient is and unfortunately just wait until they lose consciousness. At that point in time, they would actually switch over to implied consent, and then you would be able to render aid. And a good thing is that as you obtain consent, that will actually segue into your primary assessment or your primary survey. The typical mnemonic primarily used to perform the primary survey is AVPU. A standing for alert, V for voice, P for pain, and U for unresponsive. It's generally a quicker assessment than the Glasgow-Coma scale, which can take time to actually calculate. And I believe that the individual points of AVPU are pretty obvious, but A is if the patient is alert, V is if they're only responsive to voice, P is if they're only responding to pain, and U being completely unresponsive. After you've obtained the primary survey using AVPU, you'll move on to the secondary survey, which is generally performed with the mnemonic MARCH. MARCH stands for massive hemorrhage, airway, respirations, circulation, and then H stands for two different things. The first is hypo or hyperthermia, and then the second being hike or helicopter. And we'll get into those a little bit more in a moment. MARCH is essentially set up in a way that you need to deal with the most life-threatening condition first. So in a situation of trauma, it'll be massive hemorrhage. If you don't stop any bleeding right away, the patient will actually exsanguinate before you have a chance to even adjust their airway or check their circulation. And when it comes to massive hemorrhage, there are generally 5 places where blood can hide, and that's it. Using the mnemonic CARTS, you can remember that's in the chest, abdomen, retroperitoneal space, the thigh, or on the street, meaning that the blood is no longer in their body, it has actually left their body and might be found on the ground. Airway is actually quite easy to assess if they are breathing cleanly or speaking without any garbled or sonorous respirations, then their airway is going to be patent. Respirations you can check pretty easily by looking at how quickly they are breathing. If they seem to be struggling to breathe or are very tachypnic, you're going to be concerned about their respirations. Circulation is generally checked by assessing pulses. Now, traditionally, we were taught that a radial pulse corresponded to a systolic blood pressure of 90, a brachial pulse corresponded to a blood pressure of 80, and a carotid pulse to a minimum blood pressure of 70. We know based on studies that this isn't actually true in all people, but it might be the only assessment tool you have in the field to get a rough estimate of somebody's blood pressure. And then moving on to H, first you have hypo and hyperthermia because those are things that you might need to intervene on relatively quickly to prevent death. The second point here is hike or helicopter, and that's just there to get you starting to think about how are you planning to evacuate or extricate this patient. Are they going to be able to walk out with assistance, meaning hike, or will they need to be evacuated with a more advanced medical team, helicopter? After ensuring that the patient is not in immediate risk of death, it's a good idea to move on to gaining a history so that you can determine what actually happened. Again, we like mnemonics in the first responder world, so we tend to use one known as SAMPLE. Signs and symptoms, allergies, any medications the patient is on, any past medical history, when is their last meal or their last menstrual period, and then events leading up to whatever injury or medical condition occurred. So that's essentially the actual history, the history part of an H&P. If you have come across a patient who is having altered mental status, there's another mnemonic that we often use to sort of give us an idea of the differential diagnosis of such a situation, and that is AEIOU TIPS, TIPS. Now, I'm sure you already know that there's many iterations of AEIOU TIPS. I put one together here that is a little bit more specific to the wilderness environment. And I'll touch on a few of those points. Moving to E, environment, might be hyperthermia or hypothermia. O, oxygen, if you are at high altitude and you are experiencing high altitude cerebral edema or hypoxia. Under I put in INH because you might be in an area where a large number of people are being treated for latent tuberculosis, and INH can actually precipitate seizures if the patient isn't taking the proper co-medications with it. So these are just things to consider when you are out in a wilderness or more remote region and you have a patient with altered mental status. The next thing we're going to move on to is actually a triage approach in a mass casualty incident, or an MCI. Again, we use mnemonics, and this is called a START triage, which stands for Simple Triage and Rapid Treatment. And the way this works is that there are essentially four different elements or four classifications that any patient can be broken down into. Black is essentially someone that is pulseless or has injuries that are easily identifiable as not salvageable under a certain situation. For example, if you were in a team that was responding to a large bus accident and you came across somebody that had an obvious open skull fracture and there were 29 other patients to be evaluated, you would essentially black tag the open skull fracture, knowing that their likelihood of survival is near zero. Red is somebody that needs immediate intervention to prevent death, and these might be patients with arterial bleeds that need a tourniquet, tension pneumothorax, which needs needle decompression. A unique situation would be somebody who is pulseless after a lightning strike, and again, that'll be discussed further in the lightning lectures. But essentially, anybody that is salvageable if they receive specific, reasonable, immediate attention is classified as red. Yellow is anyone that is injured but is not determined to be life-threatening or not life-threatening within the next few hours. This doesn't mean they don't need any intervention, it just means that their intervention can be delayed and they will still likely survive. The final classification is green, which is minor injuries. These are patients with your bruises, your contusions, your minor fractures. We often call these the walking wounded. And a good way to assess for green patients in a large casualty situation is to simply ask anybody if they are able to walk towards you to please identify themselves. And generally speaking, the patients that are able to ambulate to you will be classified as green. Now that might not go for every patient, but that's a pretty simple way to sort of easily weed out the serious from the non-serious patients pretty quickly in a large mass casualty event. And here I've enclosed the algorithm for START triage. Feel free to pause the video and take a look at this. And finally, as part of the START triage, they often use the saying RPM 3, 2, can do. And that's a quick and easy way to sort of assess somebody's respirations, circulation, and mental status. And essentially the R stands for respiratory rate, and that correlates with the number 3, 30, if the respiratory rate is greater than 30. If the radial pulse, P, is absent or greater than 2 seconds of cap refill, or if they're unable to follow commands, decreased mentation. The RPM 3-2 can do is a system where if you identify that somebody falls into that criteria that I've just outlined there, they might be classified as a red tag and need more immediate intervention. So again, this is just a very brief description and lecture on patient triage and assessment with a focus on the wilderness environment. Depending on what resource you use in learning this on a more advanced level, some of the language and some of the terms might vary, but overall the general approach is the same in regard to the primary and the secondary survey, the history taking, and then the START triage for a mass casualty event.